Hi, Mike Gibson, Jay Giri, coming to you live from SCAI 2016, talking about TAVR and sedation. Big issue these days, general anesthesia versus conscious sedation. I have to tell you, I'm such a big fan of conscious sedation. As a patient, I had my finger repaired. I had a neurovascular bundle problem, and they repaired it under conscious sedation. I had a colonoscopy under conscious sedation. Had no idea that I'd had the procedures. It's quite heterogeneous what we mean, though, by conscious sedation, right?
I think that's a great point, Mike. Actually, when we talk about moderate sedation, especially how we're defining it in this analysis, there's really three different levels of moderate sedation that exists. At the lowest end, we're talking about local anesthesia alone.
Right.
As you move up the scale a little bit, you go to conscious sedation, what you're used to getting in the cath lab. What we use is a little Versed and fentanyl.
Right.
So-called twilight anesthesia. Then you have the highest level of still moderate anesthesia, or moderate sedation, where you have monitored anesthesia care, or MAC anesthesia.
Right.
There's an anesthesiologist there, or at least a CRNA, who can adapt to unique settings, use volatile anesthetic agents they're trained to use, and if conversion is necessary, it can ideally happen seamlessly. So there are three different levels of what we consider moderate sedation, but the key is that all of them are short of intubating a patient and having complete unconsciousness.
Right. So going into this, what was your a priori hypothesis about what would be better? General anesthesia or conscious sedation?
Yeah, I guess our hypothesis, one issue, what we expected to see was a little bit different. What I honestly expected to see was that we'd find relatively equivalent results between general anesthesia and moderate sedation. It was hard for me to believe based on our own practices at Penn, where we've been treating patients with moderate sedation for TAVR for about a year and a half, 2 years, and we've had good results. It was hard for me to see there was going to be some horrible signal of harm. But that being said, hadn't been looked at, and that's kind of what we expected was relative equivalence in terms of hard endpoints.
Sure.
Now, other issues which definitely raise people's concerns are, how about procedural success?
Right.
How about conversion rates? So some of these other things we're also trying to delve into.
And of course,
in this
length of stay, right?
And then length of stay is an extremely important issue, especially in this world we live in, where we're being held to a high standard.
You thought they'd probably be equal with a little shorter length of stay in the conscious sedation arm, and then what did you find?
Yeah, so actually when we actually looked at these patients, and it was about 12,000 total patients, it's important to understand that we actually limited this to patients who were treated with percutaneous, fully incisionless transfemoral TAVR and only elective cases. So we tried to have a clean cohort. We were trying to isolate the effect of anesthesia on them. So we didn't adulterate it with patients who are treated in a wide variety of ways. So in these 12,000 patients, about 16% of them received moderate sedation. And we saw that rate is rising over time. In the most recent quarter, it's more like 25 to 30%, but about 16% over the time period we examined. And we did an adjusted analysis where we matched along 51 variables, so it would be called a very non-parsimonious propensity match. And we saw actually that 30-day mortality was statistically lower. There was an association with lower mortality. It was about a 1% absolute difference. 4%,
but a relative risk.
But a relative risk reduction of about 25%, 4% versus 3%. 3% in the moderate sedation arm after this very aggressive matching.
Do you believe it's real?
Yeah, I think that the question that comes up is, what could possibly explain this? Well, I think one thing we have to do is step back and say, who are these patients we're looking at? Well, they were commercial patients. These are high-risk patients in the area we're looking at, 2014 to 2015. And in those patients, you could hypothesize some mechanisms why this might be the case, that putting people under general anesthesia who are at that risk, may be associated with some hemodynamic perturbances that are higher than what they might experience with a more moderate form of anesthesia. And you might also be able to keep their own intrinsic adrenergic autonomic responses intact with moderate sedation in a way that may not be possible with general anesthesia.
Right.
And then lastly, it's what you mentioned. If length of stay matters, maybe it actually has more of an association than just making your administrators happy. Maybe it is, maybe mobilizing this group of patients in particular earlier and getting them out of the hospital earlier to where their normal quality of life is, has some kind of 30-day benefit. These are the hypotheses.
Well, intubation itself,
and then of course, intubation itself.
Do you know what they died of? What was the excess mortality?
Yeah, that I'm not able to tease out with where we're at right now. Right now we have a checkbox that's very accurate for 30-day death. That's a hard endpoint. There was not really much of a difference in 30-day stroke rates.
Interesting.
It was very marginally, it was not statistically significant, very marginally different. And I'm always a little hesitant to plug stroke rates in the TVT registry because it's not neurologically adjudicated stroke.
I see.
but the death is very hard, and that's why we set that as our primary endpoint, and that we see. So no, the answer to that simply is no, and I always need to also have the caveat that it's still an observational study, but this is going to be a hard thing based on what we're finding in terms of mortality rates that are continually dropping with TAVR to study in a randomized fashion. Based on my kind of back of the envelope calculation that I made, to say if we powered this, if we had the similar event rates in a randomized trial, and we were looking for superiority of moderate sedation over general anesthesia, looks like we'd need almost 5,000 patients to be randomized.
Yeah.
It's going to be a trial that's going to be very difficult to get
That'd
done.
be tough to do.
So this may well represent the best evidence we have to support this type of process of care that is happening on its own right now.
And as we move towards more intermediate risk patients, this obviously may be a better fit as well.
Yeah, and it feels like if it's already working in the high risk patients, it's a little hard to believe as you move to intermediate risk cohorts,
Right.
so it can't even be more advantageous. Certainly anecdotally in our experience, we've treated a lot of intermediate risk patients in an FDA approved registry,
Right.
over 100, and certainly that's our therapy of choice, and
Sure.
they have very short length of stays.
Sure. Well, Jay, thanks for joining us.
Thanks so much.
You ask an honest question, you get an honest answer. Sometimes you get a surprise.
Yes.
Thanks for joining us today. And thanks to all of you for joining us here live from SCAI 2016.